Tudo bem, bom dia a todos. É um prazer recebê-los aqui nessa atividade online do Simpósio Internacional organizado pelo Comitê Científico da SARS-CoV-2 da Unesp, né? E dizendo para a doutora Derby, né? Starting our activities today, we have the honor of having the presence of the professors Anna Derby and Rosana Richtmann. Eu vou, às vezes, falar alguma coisa em português e outras em inglês para que a doutora Derby possa nos acompanhar. Well, let me introduce you first. The Dr. Anna Derby is a doctor, professor in Johns Hopkins Hospital, and her research involves the evaluation of experimental vaccines in human clinical trials. At the Center for Immunization Research, she has been conducting numerous clinical trials of many different pediatric and adult candidate vaccines, including vaccines for SARS-CoV-2. Today, she will address the topic, booster doses, are they needed? Dr. Rosana Richtmann possui graduação em Medicina pela Faculdade de Ciências Médicas em Santos, doutorado em Epidemiologia Hospitalar pela Albert Ludwig University de Freiburg, na Alemanha, pertence a diversos corpos clínicos, né, de vários hospitais em São Paulo, na área de infectologia, principalmente no Hospital Emílio Ribas, que é a principal referência do Estado em doenças infecto-contagiosas, e também ela atua em comissões de infecção hospitalar e outras atividades da especialidade, no Hospital e Maternidade de Santa Joana, no Comitê de Imunização da Sociedade Brasileira de Infectologia e no Hospital Promatre. A doutora Rosana vai falar para nós a respeito da performance das vacinas que são disponíveis hoje no Brasil contra essas novas e preocupantes variantes. Ou seja, para que Dr. Derby understand, Dr. Rosana will address the topic performance of vaccines available in Brazil against borrowing variants. And in addition, primeiro em inglês, in addition to the topics that will be covered by the guests, there are also two other important issues regarding vaccines that must be remembered. The first one is about the use of different vaccines, mainly in the booster dose. Because there are many people in Brazil that want to understand what we gain, what we get when we use two different types of vaccines. And the second point is the perspective of the need to vaccinate the entire population annually against SARS-CoV-2, as happens with the influenza, or what will be expected in the future about SARS-CoV-2. I say thank you again for our guests, and Dr. Celia asked me to thank the guests today and to justify her absence due to a slight discomfort. Good luck, Dr. Celia. Well, first, I invite Dr. Derby to start. Thank you.
Great. Wonderful. I want to thank everyone for having me today. It's my pleasure to be here. I wish I could be in Brazil in person. It's one of my favorite places to visit. But I'm going to talk today about COVID booster doses and are they needed, because it's been a huge topic of discussion here in the US for many, many weeks. And when I start to talk about booster doses, the first thing I want to bring to your attention is the difference between waning immunity and what we measure as immunity and waning protection. So we know that antibody titers decline over time. And for these COVID-19 vaccines, we're primarily measuring antibody as a measure of immunity. And I'm showing you here some titers from different studies. The titer on the left is looking at the titers induced by the mRNA Moderna vaccine over time and measured by different assays, including ELISA to the receptor binding domain, the pseudovirus neutralization assay, and the live virus neutralization assay. And it's these measurements go out to about 6 months, and you can see a very nice boost in antibody titer following the second dose of the vaccine, and these titers decline over time. And on the right is a panel from the Pfizer mRNA vaccine study, and we see the same thing, the decline in antibody titers over time. But this is natural, and it happens whether we get vaccination or whether persons are infected with COVID. We see these waning antibody titers over time. And the question is, does this mean that the vaccines are losing their potency, that we're seeing vaccine failures? And that's what I'm going to address in today's talk. Should we be worried about these decline in vaccine titers? And does it mean that the effectiveness of the vaccine is decreased against both infection as well as against severe disease? And that's what I'm going to discuss today. One point that I do like to make, and something that we don't hear so much about because it's more difficult to measure, is our memory response, because I think that's really the key when we look at vaccines or we look at natural infection. We're not relying solely on antibody titers that are in the blood at the time of infection to protect us. We're relying on our memory immune response. And there's a memory B response that makes antibodies, and of course, the T cell response that can clear virus after infection. And a very interesting study that was done by Goel in Science Immunology demonstrated that the number of memory B cells that were induced by these vaccines didn't correlate necessarily with the antibody titer post-vaccination. So even with lower antibody titers, there were still very good numbers of memory B cells induced by these vaccines, which is very encouraging. And we know that the memory response can reduce disease severity after infection occurs. And I think we have to take all of this into consideration when we're discussing, do we need a booster dose? And if we need a booster dose, when will we need that booster dose? So I'm going to go through now data that were presented at the ACIP meeting, which is the meeting that discussed, the CDC meeting that discussed booster doses. It's the Advisory Committee on Immunization Practices. And the data that were presented during those meetings that led to the US and CDC's recommendation about who should get boosters, if anyone, and when should those boosters occur. So I'm going to be discussing several different data sources that looked at the incidence of breakthrough infections and the severity of those breakthrough infections following vaccinations here in the United States. And some of these studies did include, you'll see, did include the height of the Delta outbreak here in the United States, which really occurred in early July. And we're now seeing, since about early October, we're seeing the decline in those cases. But what I'm showing you here are vaccine effectiveness against COVID, really about effectiveness against hospitalization by month and age group of the two mRNA vaccines that are widely in use here in the United States. And this is broken down by age. And what we're seeing here is that there's really no significant difference in vaccine effectiveness against hospitalization by age group or calendar month. And that means that includes the Delta variant. So these are fully vaccinated people, and you can see the different age groups with 65 and up, 65 to 74 here in the blue, and then 75 and older there in the red. Now we want to look at differences against infection and hospitalization, because we keep hearing about these breakthrough infections, particularly since the Delta outbreak. But how does vaccination impact those breakthrough infections? And are we seeing the same increase in hospitalization with those breakthrough infections? So these are data from New York State, and they linked laboratory data, immunization data, and hospitalization data to estimate the vaccine effectiveness from May 3rd through August 29th. And again, that does include the Delta variant. I'm showing you here just the breakdown by vaccine. So most of the people got the Pfizer mRNA vaccine. Fewer people got the J&J adenovirus vectored vaccine. But you can see here the Delta proportion increased significantly to essentially being the only variant circulating in August here in New York State. So what I'm showing you here is vaccine effectiveness against infection, against COVID of any severity. And what we do see is that the vaccine effectiveness against new COVID-19 infections did decline from 92% on May 3rd through 9th to about 73% when Delta reached 85% circulation. It then declined and plateaued around 77% here. So you can see the decline in vaccine effectiveness really for all age groups over that time period, and the rise of the Delta variant here. Now, when we look in those same data sets against vaccine effectiveness against hospitalization, what we see is excellent effectiveness against hospitalization. It remains stable at 90 to 95% throughout this entire period, including the rise of the Delta variant. So although we saw increased infections, we saw excellent effectiveness against hospitalization. Looking at another network data point, and this slide is from the CDC, and it's just showing you where they're collecting the electronic health records in their Vision multi-state network. Again, we're looking at vaccine effectiveness against hospitalization for adults 18 years of age or older. They took the data from COVID-like illness with positive PCR and then controlled. It was a case negative controlled COVID-like illness who were negative for PCR. The median age of the cases was 65 years of age, and vaccination was documented by electronic health records and city registries. And this is what we see. What I'm showing you here is different time periods, January to May, and then June to August. And unfortunately, this looks like it was cut off a little bit. But these are different age groups. This is 65 and older. Again, this is 18 to 29, 30 to 49, 50 to 64. And again, we're looking at vaccine effectiveness against hospitalization, and we're comparing up top here the Pfizer vaccine versus the Moderna vaccine. And again, we see really, really excellent effectiveness against hospitalization for these vaccines, with a bit of a drop, particularly in the Pfizer vaccine, in those who were 65 and older. So we did see in one age group, 65 and older, a drop in effectiveness against hospitalization, particularly for the Pfizer vaccine. Now, another network that we have is the Supernova network, and that also accumulated data on hospitalizations. And again, this was a test negative case control assessment that looked at a period from February through August, so really at probably the mid-peak of the Delta outbreak. And this was looking at veterans who tend to be older in the United States and have more comorbidities. If you look at the demographics, you can see the median age was 68, so a much older population with a lot of comorbidities, hypertension, obesity, and diabetes. And again, when we look at these different vaccines, and we look at the effectiveness against hospitalization, it did drop in this older than 65 population, again, particularly for the Pfizer vaccine, from 92% to 77%. But for those 18 to 64, we saw excellent maintenance of that effectiveness against hospitalization. We did see some drop off in those who were 65 and older. When we look at it pre-Delta versus Delta, I think what's really important to look at is there's really no difference in effectiveness. The effectiveness was maintained throughout the Delta outbreak. So these vaccines maintain their effectiveness even against the Delta variant. And again, this is effectiveness against hospitalization. So when we look at these different studies, what I've tried to show here is in red is the vaccine effectiveness against hospitalization. In blue is vaccine effectiveness against infection. And we definitely do see a decline in effectiveness against infection, but the effectiveness against hospitalization really looks to be well maintained for most groups. There is a drop off in the older population, 65 and older, particularly for the Pfizer vaccine. So when we look again at time since vaccination, adults greater than or equal to 18 years old without any immunocompromising conditions, we had a study that could look at all 3 vaccines. And we did see, again, what we saw here, a drop-off with the Pfizer vaccine. Moderna is very well maintained. There really weren't quite enough data for Janssen. We did see a decline over time. Again, the J&J vaccine is a single-dose vaccine. But for the most part, these vaccines held up pretty well. And again, when we look at younger age groups, that holds up very well over time. Older age groups, we do see a decline in vaccine effectiveness against hospitalization. And this is what really drove the ACIP recommendations. This is another network data that I'm showing. And this is breaking groups up by pre-Delta or post-Delta with no underlying conditions, with more than one underlying condition, hypertension or obesity. And again, we're seeing that these vaccines hold up very, very well, even through the Delta outbreak, and even in people who have more than one underlying condition. Now, I want to just touch very briefly on heterologous prime boost, because the ACIP just had, or the FDA just had a meeting, and this was discussed. And it appears at the next ACIP meeting that they're going to take up and approve heterologous prime boost. And what do I mean by that? That means if you got an mRNA vaccine, you were then boosted, and that by boosting, I mean your third dose of vaccine was the J&J vaccine, or if you got a single dose of J&J vaccine, your second dose was an mRNA vaccine. And what we see is heterologous prime boost really improves the immune response with that third dose if your first 2 were mRNA, or with your second dose if your first dose was a J&J. So here are the 3 different vaccine candidates: adenovirus, mRNA, and you're boosting with the Moderna mRNA. And what we see here with all of these, we get excellent boosts in all of these titers. Now, you can compare the different platforms across here. So this now is, you got an adenovirus boost and you were boosted with adenovirus. If you got started with an adenovirus vaccine and you were boosted with mRNA, you got higher neutralizing antibody titers with that adenovirus versus followed by an mRNA boost. And again, if you started with Pfizer and you got an mRNA boost, you had pretty much the same response regardless of what your first vaccine was. So these were preliminary data that were released, but it appears that the prime boost platforms do work very well. And right now in the US, you can get, you don't have to have a matched, if you do get a boost in a booster dose, it does not have to be matched. You can have a mixed platform boost. So the FDA ACIP recommendations for boosting came out. The FDA authorized booster doses for the elderly, those living in long-term care facilities, and persons at higher risk of contracting COVID, or persons at higher risk for severe COVID. Initially, the Advisory Committee for Immunization Practices recommended booster doses for the elderly and those living in long-term care facilities. However, the CDC director then went on and expanded this to include healthcare workers, those who are 18 and older and those who are 18 and older with underlying medical conditions, and those who are 18 or live or work in high-risk setting. Now, last week, the ACIP met to recommend booster doses, to discuss booster doses for Moderna and Pfizer. For Moderna, the booster doses were recommended to match these, which were originally done for just Pfizer. For the J&J vaccine, a booster dose is recommended for everyone who got the J&J vaccine, particularly because of the waning protection that was seen over time with that single-dose vaccine. So in summary, these vaccines are highly effective against symptomatic and severe disease. The Pfizer vaccine was authorized for those 12 and older. We are going to have an ACIP meeting probably next week FDA is meeting, has looked at the data for those 5 to 12. And they will be meeting tomorrow to discuss authorization for the Pfizer vaccine for those children 5 to 12. Pfizer is authorized for those 12 and older. Moderna is seeking authorization for a pediatric population, but that has not been reviewed yet by FDA. FDA is requesting more data, particularly around the issue of myocarditis and pericarditis. I do like to stress that prevention of infection is a very high bar for respiratory viruses, for any respiratory virus vaccine. We need to get antibodies, particularly to the nasal mucosa, which can be difficult when we're giving vaccines intramuscularly. But the important public health impact is prevention of hospitalization. If we can prevent severe disease and prevent hospitalization, we can prevent the stressors on our hospital infrastructure and healthcare infrastructure that we saw with COVID. The data do support booster shots for those 65 years of age. They don't strongly support booster recommendations for other groups, as we're seeing very, very high protection for all groups other than the 65 years of age. And even the 65 years of age, we still see very good protection, but it did decline over time. And the point that I always like to make is that if we want particularly, and I realize I'm talking very much US centric, but if we want to prevent, spread of the Delta variant, if we want to prevent spread of COVID of any variant, really booster doses isn't the answer. We have to get everybody who's not been vaccinated yet vaccinated. That really is the way the only way that we're really going to stop COVID is to get all of those people who have yet to be vaccinated. And I think that's really the important message. Boosters can help prolong the prevention of hospitalization for those 65 years and older, but we really need to get as many doses of vaccine to the rest of the world as we possibly can. And I think that's my last slide, so I'm going to stop sharing now. And if there's anyone who has questions or comments, I'm happy to take those.
Congratulations, and thank you very much, Dr. Durbin, for your bright presentation. Thank you. I will invite Dr. Rosana to start, and then we will have the questions, okay? Doutora Rosana, queremos ouvi-la. Bom dia, obrigado por ter vindo.
Good morning, everyone. Thanks for the invitation, and I hope you are now seeing my presentation. So, is it okay? Are you seeing my presentation?
Yeah.
Good. So, thanks again, Anna, for the presentation, because it is easier to talk now about all these subjects, and Sergio and Carlos Magno also. So, I'd like to talk with you about the performance of vaccines available in Brazil and the variants of concern that we have here. Here is my disclosures and where we are in Brazil. That's the first question. So if you see here in Brazil, we are the third country in the world in regard of number of cases of COVID-19. And in regard to deaths, we are the second country in the world. And also, when we see deaths per million population, we are the 9th country in the world. The first one, unfortunately, is also in Latin America, is here in Peru, but Brazil is the 9th one. So where we are not so good. That's the conclusion. Now let's see what about the new variants in Brazil. So what we have from data, we can see here the first wave in Brazil that was last year with the original strain, the Wuhan strain. Then the second wave, where in Brazil we had almost 100% of gamma variant of concern. And now, more recently, we have the predominance of Delta variant in Brazil. When we see the deaths, when we see deaths related to the 3 different waves in our country, we can see here, but of course it wasn't a period that our population is not so vaccinated, so it was not necessarily related to virulence of gamma, but also because of no vaccination of the population. But we can see here that in second wave, we had lots of death cases. It was a catastrophic sanitary situation in our country. Now, in regard to Vox in Brazil, Ana had just presented the data from US, and here from Brazil, you can see here August 21. We have most of them in green color. That was the gamma VOC here in August. And here in purple, it was Delta just beginning in August this year, 21. And then when we go to September of the same 1 month after that, we have already here 91.8% of Delta. So although we had the gamma VOC here in our country, in a very short time, Delta came and had almost 92% of predominance in our country. So what about vaccination? How are Brazil in terms of vaccination? Here we have good news. We are not so bad as we are in regard of case and deaths. Brazil in Latin America is the 4th country in terms of number of immunized population. We have today around 51% of the Brazilian population with 2 shots, that means fully vaccinated, and almost 75% of our population with at least 1 shot. So Brazil, we are a large country, and we in a short time, I guess we can, and we know how to perform mass vaccination in our country, and that's why we are the 4th country in terms of percentage of the population vaccinated. In terms of number of doses administered per 100 people, we are also good because, as I mentioned, we are lots of people. So we start late, but we are running in terms of vaccination, and that is because Brazil have a good background in vaccination, a very high capillarity for perform vaccination in different parts of our country. So what is our menu, our vaccine menu in our country? We have 4 vaccines that are approved, 2 of them for regular, fully approved, and 2 of them for emergency use. So CoronaVac and Janssen is just for emergency use, and AstraZeneca and Pfizer is definitely approved in our country. And now I would like to see some advantages and disadvantages related for the vaccines that we have in our country in order to understand what's going on in terms of VOC. For instance, CoronaVac, that is an inactivated vaccine, CoronaVac, we have the disadvantage is a low immune response, low protection, low duration of protection, worst for immunocompromised and elderly people. But the advantage, and it was really good, it was the first vaccine available in our country. So we have the availability in our country, it's a safe vaccine, and it's a known platform. So it was really good in the beginning of vaccination in Brazil, but now I'm not so sure because of Delta, because of the new variants that we need a higher level of antibodies. About AstraZeneca, The disadvantage is safety concern, for instance, about pregnant women, lower protection for Delta. We don't know, but we know that we need more antibodies. Missing data for Gamma. We have some data about Gamma. And in Brazil, 2 shots with 90 days of interval. And it's a disadvantage because it can induce a lower coverage for the second dose. The advantage is available in Brazil, is national production and good immune response. What about Janssen for us in Brazil? The disadvantage, again, is safe concerns, pregnant women, lower protection for Delta, as we can see. We also have calm data about Gamma, not so much data, just 1 shot. And I put an interrogation mark because I don't know if it's a disadvantage or advantage, because we know that probably we will need the second shot, so we have to take everyone again for the second dose. And duration of protection also, it can be a little bit shorter. And the advantage of Janssen is exactly because it's just 1 shot. So, for instance, in difficult region like Amazon region, it's a huge advantage. And Pfizer in Brazil, also safety concern, adolescents, lower protection for Delta because of the level of antibody, the neutralizing antibody, missing data for Gamma. We have less data in Gamma. 2 shots in Brazil with 90 days of interval. It was in the beginning, and again, the coverage can be lower. The cold chain for Brazil is a problem, and of course, the costs. The advantage of Pfizer vaccine is available, national production in the future because of TransTech, good immune response, better immune protection for elder people, immunocompromised people, safe for pregnant women, and also we have and will have more data in adolescents and pediatric population. So with all this picture, we can see here the effects on vaccination in our country, how the distribution of vaccines in Brazil. And Brazil is the only country in South America that has 2 plants for vaccine production. It's Butantan and Fiocruz. Most people willing to get vaccinated. It's a huge advantage in Brazil. Most of state capitals with about at least 50% of the population fully vaccinated. And we estimate that at the end of this year, about 8% of Brazilian population will be fully vaccinated. So we are for vaccination, and it's a huge advantage. About the Vox, we know that Delta, for instance, is much more transmissible. It's in short time dominant. The virulence, it seems not to be true, that it's more, the virulence is higher. Also about mortality, not clear. And perhaps it can escape for immune response, mainly with the inactivated vaccines that we have a lower initial level of neutralizing antibody. And here, of course, it's from CDC, the transmission of Delta that they compare a little bit with chickenpox. So it's really much more transmissible. Here is not so recently publication, but very clear because it was one of the first one about how many neutralizing, the level of neutralizing antibody. That means that high predicted immune protection for symptomatic COVID if I have a higher neutralizing antibody in the beginning. So when we compare here, for instance, CoronaVac, the inactivated vaccine with the 2 vector vaccines and with a Pfizer vaccines, it's really very different. And that can, seeing this kind of picture, we can understand why we need, I think we need a booster shot for all people that got the CoronaVac, mainly the elderly people, healthcare workers, and so on. And here, sorry, it's in Portuguese, but just to see this here, this graph, That's the level of protective efficacy of coronavac, and here the vector virus vaccines, and here Pfizer vaccines. So it's very different for symptomatic infection. It's not so different about hospitalization, death, and severe case, but for symptomatic infection, this kind of response makes a huge difference. And here also, if we start with a vaccine with 7% of efficacy, and when I compare with another vaccine with 95% of efficacy in the beginning, we can see that, for instance, for severe infection, the protections remain a long period, but for mild infection, it can be lower in a shorter period of time. And here, the real world, the effectiveness of Alpha and Delta, when we compare different countries, England, Canada, and Israel, and also Brazil, we can see that if we have Delta, that is the red triangle, or if we have Alpha, we can see that for hospitalization, for confirmed infection and symptomatic disease, it made no great difference. And when we compare with Israel, it's completely different, this effectiveness. So one of the difference between this kind of countries is the interval between the first and second shot. For instance, in England and Brazil, it was 3 months, Canada 4 months, and Israel 3 weeks. So it's not clear, but it was a difference when we compare different schedules of vaccination. And in UK, it's a very good example, because in UK, they have, although they have new cases more recently, the hospitalization and new deaths was not going together. So exactly how Anna had just presented in New York and in US. But everyone saw this weekend and the end of the last week that the number of positive tested people in UK that have not used any more masks and no distance, no pharmacological measures, they are seeing an increase in the number of tested positive people, deaths. Are down, and we hope it continues. Supply issues, pregnancy, flexibility, and also when we have serious adverse events. So it's good for Brazil to have data in mix and match vaccination in prime and other. And here is a clinical trial that is going on. It's almost done here in Brazil. Population with 2 shots of coronavac took the booster dose, one of the 4 vaccines that we have, and the results we will have in the next weeks in order to see how was the experience with 2 coronavac as we had here in our country. We need to have our data. Here is the publication from Júlio Croda group about the effectiveness real life with coronavac in older adults. It was performed here in São Paulo with gamma variant. And what we see in elderly people, more than 70 years, the prevention of coronavac for disease with the first shot was just 12.5%. The performance for 2 shots in regard of disease was almost 50%. Hospitalization, 55th, and death, 61.2. but here is real life, gamma variant, and also elderly people. Here is the same publication, but just to see in the elderly people, when we compare 74-75 and over 8 years old, it's huge difference in regard of effectiveness. So this population, they need, in my view, they really need a booster dose because they got 2 inactivated vaccines. Here we can see also data from Manaus, from Brazil, and it was gamma variant. It was our variant. And here is the symptomatic cases in red going down, because in green is the first dose and here is the second dose. So it's very clear the effectiveness in real life from gamma and the vaccination in healthcare workers in Manaus. Here is another publication from the Sue and Clemens and group about the AstraZeneca vaccine in Brazil. And just for us to see for P2, that was another variant that was in Brazil, the efficacy, its effectiveness was 7-8%, and for gamma it was 6.3, but it was just 18 cases, so we cannot have a good information about that. And here also from Júlio Croda group, it is effectiveness of AstraZeneca in São Paulo with gamma variant. And we can see here that with two doses, after 14 days, we have for death protection 93.6%. And with just one dose, 37.5%. So we do need the second dose for all these population that gets the first dose with AstraZeneca. Here is another publication also from a Brazilian group about the effectiveness when we begin to vaccinate. Here is the vaccination cover in this graph. And here is the decline of disease and death in this population, this elderly population. So again, with gamma variant, we have very good results. And to the end, it was very recently a publication, October now, last week, also about Janssen vaccine and also for Brazil. Gamma was predominant and Delta was rapidly emerging during the study period. And for Janssen vaccine, the effectiveness for disease was almost 51%, hospitalization 72%, and deaths 90% of effectiveness. So all Brazilian data. Ana has already mentioned about the decline of neutralizing antibody, and perhaps it's not the best surrogate marker that we have. We do have to think about them. It's really important to decide who needs a booster dose. And just one example for Brazil, for Ana, with Coronavac in Manaus, is north region of Brazil. After 4 to 6 months, we have a decrease, a very important decrease in neutralizing antibody with gamma variant, gamma VOC. So we can see a very short period of protection. But the good news is after 6 months, when you give a booster dose with Coronavac, it's not a Brazilian data, it's from China, but it's the same vaccine. We do have increase of antibodies and also cell immune memory response. So in conclusion, I think we have how long will vaccines protect? We don't know exactly. That's why it's very important for Brazil to have our own data in order to discuss all this these issues about booster, who will get, when, which vaccine. All this information is very important, and we do not have to import data. We have to have our data. And that's why it's so important to show this kind of data. So clinical trials is something and real life is something else. So that's why it's very important. And with that, I end my presentation, and I will be very glad to be with you in the discussion. Thank you, Sergio.
Okay, Dr. Rosana, thank you. Thank you, Dr. Durbin, one more time. And now we have the Professor Carlos Magno to take over the works. Okay, Carlos, it's with you.
Hello, thank you, Professor Durbin. Thank you, Rosana, for giving us such robust speeches and in a subject in which you have many doubts. And so I hope you have time for a rapid debate. We have some questions here. I already asked Professor Durbin if I can repeat now, because now everyone is can see the answer. And so I will go on with the question. So Professor Célia Nogueira asks if health professionals do need a third dose, in which I would suggest a secondary question, which is if healthcare workers are preferential for those doses, if they should be vaccinated before other groups. So this is the question.
Do you want me to start? I can start with that. So, and again, I think I'm speaking from my experience, which may not be the experience in other countries. And I want to make sure that that's clear. We know from data at Hopkins and in the US that most healthcare professionals are not infected at work at this time. We're in a very different position today than we were at the beginning of the pandemic, when PPE was hard to come by. So we know that it's not. And when we looked at data, CDC presented data on the effectiveness, long-term effectiveness of these vaccines in healthcare professionals. They were still high. They were more than 90% effective. So it's not the healthcare professionals who are getting severely ill with COVID in the United States. And that's likely because they have good PPE. But the 65 and older and people living 65 and older, I didn't talk about those who are immunocompromised. That's a different set that clearly needs a third dose as part of their primary series. But really, the 65 and older are the group that should be prioritized for booster doses, because those are the people that we are seeing coming back to the hospital requiring hospitalization. I think a lot of healthcare professionals certainly would feel more comfortable getting booster doses. And we've seen that here in the US, where they're going for booster doses. But it doesn't appear that in the US, healthcare professionals that are higher risk for more severe disease, if they don't fall into the other risk categories. That could be very different, though, in other countries that might not have access to PPE.
Carlos, can I say something about this subject? Anna, here in Brazil, we began with Coronavac for the healthcare workers, and it was January, February this year. So we have more than 6 months, at least 6 months. And as you saw in my presentation, the duration of protection, it was shorter. It was about 5 months. So that's why we saw an important number of healthcare professionals here in Brazil with severe cases of COVID. And of course, the perception for the other healthcare workers, when you see a colleague that was working in the front line, it was really not so easy to accept not having the booster dose. That's why at this point in Brazil, we are performing the booster dose for healthcare profession, for all healthcare profession with a Pfizer vaccine.
Yeah.
So we are doing the heterologous
which is excellent.
schema that we think it's better one for this population. So it's not because they are healthcare profession, but it's because they got inactivated vaccine that was great at that time, but not now.
Rosana, you make such an excellent point that I should have brought up earlier. The type of vaccine makes a difference. I think that is absolutely true. And I think one of the key differences between the inactivated vaccines and the mRNA or adenovirus boosted vaccines is the induction of T-cell responses, particularly CD8 T-cell responses. And that I truly, I think is why we may be seeing more breakthrough infections with even the mRNA and adenovirus vectored vaccines, but we're not seeing severe disease because that CD8 T-cell response can clear the virus before people get ill. We don't get that with those inactivated vaccines. And I completely agree with you that if you got an inactivated coronavirus vaccine, you will likely absolutely need a booster dose.
Yeah, good.
Yep.
You are mute, Carlos.
Sorry, my internet just interrupted for a while. But I have another question here for Professor Durbin. In fact, it's a question for both of our exposers. Professor Adriano Mondini asks concerning vaccination data in Brazil and the US, and comparing the situation that both Brazil and US have similar people fully vaccinated, but Brazil is ahead of the US with the first dose, with 75% of people vaccinated. And how do you see the perspective of the epidemiology of COVID-19 in the long run? How do you both see what happens now? How can we overcome the threats in this scenario?
Rosana, would you like to go first this time? You go first this time.
Yeah. It's a difficult answer to give because it's so many variants, not box, but variants that we have to put in the table to discuss. But I think Brazil, in terms of vaccination, we are doing really very well. We know how we have the expertise of mass vaccination in our country, and it makes a lot of difference when we compare with European countries, with US, and so on. So I think we are going in the right way. Really, we at this point we still emphasize, at least the scientists emphasize the importance of use of masks and also not crowded the non-pharmacological measures. So, Carlos, I really think for the next year, the health ministry is trying to have at least a number of need of how many doses we will need for next year, because they are thinking about the re-vaccination, the booster dose for specific groups. I guess, but I'm not sure, I guess we are going to perform vaccination also for children, at least high-risk children. We are going to perform vaccination. I don't know exactly if it will be for all children in Brazil, but the high risk, sure. And my feeling is that if we don't have, for instance, Africa region and other regions that we have 3% of one dose in these low income countries, we are not safe. We are not in a tranquility atmosphere. So I think we need to review what we are going to do. I mean, Brazil, US, the countries that can have those in order to have a better future next year. That's my opinion.
Yeah, I couldn't agree with Rosana more. I mean, I think that until the world is vaccinated, we're all at risk because we can see the rise of new variants in areas where this virus can spread. We know that, and we've seen it particularly with Delta, that mutated to become more infectious, replicate to higher titers, and take over wherever it's gone. And if there's another variant that can come through, if we have pockets of our population that are non-immune, then you can see the rise of these. And I also agree. I think until we really see worldwide immunity, whether it be induced by vaccination or unfortunately natural infection, we're going to probably have a vaccination in 2021 and maybe into 2022 just to protect against new variants coming into our country. So until we get the world vaccinated or until we get the world immune, I think you're going to see probably annual vaccination programs to prevent the rise of new variants.
Perfect. We have another question, also for both exposers. It's a question from Professor Wagner Valenti. He's asking about the Janssen vaccine. If there are data that show that the Janssen vaccine is really less effective, and I will also add a question, if a second dose of Janssen vaccine would not turn it as effective as, let's say, AstraZeneca vaccine.
Yeah, I truly believe that this is a 2-dose vaccine. I understand why they went for 1 dose because, we have to think back to just a year ago. Think where we were a year ago. We didn't have vaccines. We didn't have any vaccines. And we had the goal of getting as many people vaccinated as quickly as possible. And if you could do that with a single dose, if your vaccine was single dose, you could vaccinate twice as many people. So, but I do think that in the early stages, so if you're looking at 1 to 2 months post that first dose, it is just as effective, but the durability of that protection falls off relatively quickly. And I think a second dose would improve that durability to equal that of AstraZeneca. Certainly, yeah.
Yeah, of course I agree with Anna. Carlos, I always said that it is a 2-dose vaccine, not 1. It was just I don't know, marked a little bit,
yes,
but also, and the primary outcome from the Janssen vaccine was different from the others. That I think that was the difference. So when you compare just the 7% of efficacy, it was something different because the outcome was severe disease, hospitalization. So I think it's 2 shots. I don't know the interval, the best interval, and 2 months, I don't know. And Carlos, if I can ask Anna after them, because of the interval of vaccines, when we see the Pfizer vaccine or Moderna vaccine, and all countries that had 3 months or 4 months, like Canada, and when we compare with place with 3 weeks, as it is the official one, the clinical trials and so on, we see the difference in terms of efficacy, effectiveness for Delta. What's your opinion? Do you think this interval is really important to make a difference?
So I think the interval does make a difference. And again, when we think back to a year ago, what they're doing is trying to say, how quickly can we get people vaccinated versus how that's going to affect the outcome. And if we look just at Moderna and Pfizer, for instance, or if you look at AstraZeneca, where we had data from the UK with a 2-month interval versus a 1-month interval. And I do think for some vaccines, if you can stretch out that interval just a bit, you're likely going to get a better immune response because that immune response after the first vaccination needs to calm down. Then you give a second vaccination. And I think if you could stretch that interval to 2 to 3 months, once they're fully vaccinated, I think you will probably see more durable protection. The problem is then you risk breakthrough infections between that first and second dose. And that, and you're trying to sort of hit that sweet spot. But I do, when we looked at Pfizer versus Moderna, there's two factors that we see. We are seeing definitely better protection from the Moderna vaccine, more durable protection, I should say. I don't want to say better protection, more durable protection with Moderna compared with Pfizer. And there's two factors with Moderna. One, the dose was 3 times as much as the Pfizer vaccine, and the interval was 4 weeks. And it's hard to know which contributed more to that, but I do think the interval is important. And if you can stretch that interval, to 2 to 3 months, I think you'll get a better response with that second dose that can improve the memory response, but you're risking those breakthrough infections between first and second doses. And you're risking people not coming back for that second dose. That's the other. We probably have more of a problem with that in the US than in Brazil because you have an excellent immunization program. But yeah.
Yes, we are really proud of our immunization program, which has achieved many goals before. And well, I have another question, which is something that it's a question from Adriano Mondini, and it's something that makes me sleepless at night because it's a really tough question. Is do we all agree that instead of prioritizing a booster dose, we should be vaccinated Africa and the rest of the world in order to avoid the emergence of new VOCs?
I think that has to be a key priority. And I'm just speaking from a US perspective. I think that all of the booster dose discussions in the US really, I think we're a distraction from vaccinating the rest of the world. And I say that, and I do want to say, because we know that the mRNA vaccines and the adenovectored vaccines, you maintain high protection. The inactivated vaccines, I do think, need a third dose. But I think if we took all of our booster doses and gave them to Africa, we would have a much larger impact on COVID than giving booster doses in the United States.
Carlos, depends on who I am. If I am from WHO, of course, give vaccine for everyone in order to have a better world. If I am the master of a little town, or if I'm the government of a state, and we are seeing physicians with breakthrough infection, we are seeing elderly people with breakthrough infection, and I have the vaccine in my state because we produce the vaccine. It's very hard to have this WHO view. Of course, everyone I agree with that, but in the real life, it's very hard to have this kind of action. So I think the answer depends who we are.
Yes, I am very quite aware of that paradox because, as you, Rosana, should know, but we have an effectiveness study going on in our town. Is a small 150,000 inhabitants town, Botucatu, and we vaccinated everyone with the AstraZeneca vaccine in May and second dose in August. And the Ministry of Health was very helpful to us. So everyone here thinks the Ministry of Health is doing very well in fighting COVID-19. Nevertheless, we see that we have this enormous mortality in the country. So it depends on which perspective you have and which you are looking at. My next question is my question. I would just require the possibility of sharing my screen to show you some ecological results of our study and to prepare the question. Can you see this graph?
Yeah.
Yes.
So this is the graph of the COVID-19 cases in my town. As I said, it's a 150,000 people town. We had this vaccination with almost 100% coverage of the target population, and we had this impact of the first dose. This impact is seen both in the mortality, and when we see the mortality, or the incidence, the mortality, and when we see the incidence in terms of proportion of cases in total São Paulo state cases. And this in the last, after the second dose, which is more rapid fall in the number of cases. Nevertheless, this is the time when the Delta variant was present. So we have this, which is the evolution of Delta variant. So when we have the second dose, we were like this. These are two lineages of Delta variant with more than 80%. And even so, we saw that decrease. So my real question is, we are working with COVID vaccines with a logic of preventing death and preventing severe cases. But is it possible that in some way it really does have some herd effect, and that herd effect can make effectiveness sometimes even greater than efficacy in clinical trials, because you have a population, if the whole population impact? Because what we saw here is that cases continued falling even after the introduction of Delta.
Yeah. So I think absolutely. I mean, we know that these vaccines and I'm speaking more of the mRNA and the adenovectored vaccines because we have more data on those than we do on the inactivated vaccines. But I think, again, there's two key points to make. I think even if you see reduction in the effectiveness against disease of any severity, we're still seeing very high protection against severe disease and death. And we also see reductions in transmission. So even though you have a breakthrough infection, there are studies that have shown that you still transmit virus for a shorter period of time if you're vaccinated compared with unvaccinated. And, they have measured, there was a very, I think, well-publicized outbreak in Massachusetts in the US where most of the people were vaccinated, and they said, look, the titer of virus in unvaccinated and vaccinated was the same. But I think the key was that was by PCR. But when we look at viable transmittable virus, it's still less in vaccinated people than it is in unvaccinated people. So you can reduce transmission with vaccination. And I think that's going to be a key point because, many countries can't vaccinate children right now or aren't vaccinating children. And we know that the virus, can infect and replicate in children. And so the question is going to be, how young do you need to vaccinate if you want to totally prevent transmission of this virus? And I think if you have a highly vaccinated adult population, you'll be able to protect against hospitalization and severe disease. We know children can get severe disease, but it's much less common in children than in adults. But I do think that if we want to reduce total transmission, we have to somehow get children immunized.
I fully agree with Anna. I'm sure that in the beginning, our goal was to mitigate death and severe case. And now, of course, it's transmission. So the immunization has it has an impact, herd immunity impact in terms of decreasing the circulation of virus. And Anna, I always say that the children is a biological little terrorists, right? And for flu, it's very clear. They are the little terrorists, the biological terrorists. And I think for COVID also, it's coming always more publications that children, yes, they can have the virus, they can replicate the virus. So I think, of course, if we want to really have an impact in transmission, we should vaccinate children, but it's another discussion. If we want to minimize severe cases in children, then we have to vaccinate high-risk children.
Yes.
That's my opinion.
Yes, yeah.
Well, very well, Rosana. It's a very unbiased response because Rosana is one of the few experts in vaccines who is not a pediatrician, infectious disease specialist. So,
Me too. I'm not a pediatrician either.
So you are two rare birds, But we have one last question, and it's a question by Wagner Valenti, and he's asking about the relative importance of cellular memory compared to antibodies. And I will also add a question, which is, what is the value of people testing themselves for neutralizing antibodies after being vaccinated, which is a fashion in elite and among doctors?
Yes. So I think the cellular immune response is very important. And that's why I think when we see that disconnect between, and a really good example is the AstraZeneca vaccine in South Africa. And I think, and Rosana presented some data about AstraZeneca and the Gamma variant. So you do see breakthrough infections. We know that the AstraZeneca induces antibodies that do not neutralize the Gamma variant or the Beta variant, which was the South African variant, as well as other vaccines. But what we saw with the J&J vaccine in South Africa, we saw something similar. Antibodies don't neutralize the Beta variant as well. There were more breakthrough infections. It was very low efficacy against symptomatic COVID with the Beta variant, but highly effective against the prevention of death, hospitalization. So I believe that it's that cellular CD8 immune response that's able to control infection after it occurs. Antibodies, you need antibodies to prevent infection. You need antibodies in the nose, in the upper respiratory tract to prevent that infection. Once that infection occurs, it's primarily your CD8 cellular response and antibodies that can control that infection. So both arms are very important. And that's why I think you see differences between the inactivated vaccines and the mRNA and adenovectored vaccines when it comes to effectiveness against severe illness and even infection, because the CD4 response induced by all of the vaccines can boost your antibodies. You have good humoral cellular immunity, antibody memory response, but that CD8 response can really help clear infection after it occurs. And that's why you can have, to Rosana's point, neutralizing antibody, it is a surrogate, but it doesn't tell the whole story. And you shouldn't get your antibody titers tested. It's meaningless there.
It's good just for the labs. For the labs, it's very good, but not for the patient.
Highly profitable, right? Well, we ran out of questions, but this has been a wonderful debate. So I thank Anna Durbin and Rosana Richtmann for the excellent speeches and for these very, very inspiring responses for our questions. And as this is the closing section of all the workshop, we would like to thank all the speakers and all the people who were watching. This will be in our website recorded, but it has been very interesting. Every speech was quite full of novelties and important in answering important questions or posing more questions. So that has been perfect. And to close with this debate about variants and vaccines, it makes sense because it is really an important and practical issue in public policies. So once again, thank you, Professor Anna Durbin. Thank you, Rosana Richtmann. It's been very pleasant to be here and to moderate this debate. So with this, I will finish the debate, and thank you all again.
Thank
Thank
you.
you,
It was a
Carlos.
pleasure meeting you,
Rosana.
Rosanna. I had a lot of fun. Thank you very much.
Bye-bye. Bye-bye. Good, good.